So I would now request Mr. Mohammad Oliullah Abdul, who is the founder director of Binox Vision Therapy Software, to speak on dichoptic management of amblyopia. In fact, in Shroff, we only have the monocular element, and now with Binox, we have started the dichoptic therapy too. So he'll be telling us about the dichoptic management of amblyopia. He's the founder director of Binox Vision Therapy Software. He did his optometry fellowship research training at LVP. He has, apart from his clinical work, engaged himself in innovation and research on binocular vision disorders. So I would now ask him to speak on the dichoptic management. We will take in questions and we can debate at the end on both the therapies. So Dr. Manjula, please be ready for more questions. And over to you.
Good evening, all of you. Thank you, Dr. Suma, for this opportunity. And Dr. Manjula made my presentation very simple because she already explained all the scope of binocular management, how it can be more effective, or that we'll be debating on, but how it can be more convenient compared to the patching. So when you talk about dichoptic management, today we'll understand what are the amblyogenic defects in the visual system, a very overview. Dr. Prachi already explained on this, and then what are the expected outcomes in dichoptic management, or which patients or subset of patient is going to be benefited most from this dichoptic therapy. So as Dr. Sobita already mentioned about different kind of ATS studies. So just to summarize the drawbacks that ATS studies has. So it pointed out the residual amblyopia in ATS 2A, and then poor compliance, as many of you already explained, in both motors and rotor studies, as along with the ATS study. The other crucial factor is the slow improvement, as Dr. Manjula spoke about 10 hours versus probably 80 to 180 hours. And then recurrence is one of the major aspect in this group of amblyopia management, especially in the patching or atropine penalization. And coming to the deficit in stereopsis, that portion is not clearly mentioned in any of the ATS studies based on the patching. And if you go to older adults for the first time, yes, there are certain improvements to limited efficacy, but most of the cases it is ineffective. So being so many drawbacks into the patching, though it's a gold standard till this point of treatment. So here the neurophysiology says in amblyopia, it is the functional issues in the visual system that limits the visual maturation and the improvement of vision. So as we can see that amblyopia primarily disorder in the 4th and 5th order neurons, which is in lateral geniculate body and the visual cortex, and not into the eye level. So what happens exactly in lateral geniculate body? So if there is an early deprivation kind of amblyopia, so that affects the lateral geniculate body cells and becomes pale and shrunken. And that leads to the amblyogenic factors, and one pathway from the open eye, which is the dominant eye, took over the territory of the closed eye. And whereas in cases of visual cortex is little different in Brodmann area 17 and 4C. So this is predominantly for the ocular dominance column. So expansion of the dominant eye happens, and this results in the density or quality of the depth of amblyopia, which results into. Now, once this functional development or neurophysiology we understand from this concept, now we understand this binocular concept, as the binocular neurons are active throughout our life. So this dichoptic kind of amblyopia management we have introduced, and there are many more programs. In what happened, dominant eye received a image of a lesser contrast, as again Dr. Manjula nicely explained. The moment there is a decrease in contrast, then the brain processes binocular images by reducing the inhibitory interaction in the ocular dominance column, and thus it results in binocular activities. Now, when you get multiple gains based on this dichoptic principle, so it makes more compliant and more interactive for the child or even adult And if you have a scoring system which gives a little bit incentive for the child by playing more and more activities, that gives more engagement to the program and results in better efficacy. So this program of different amblyopia activities based on Dichoptic is giving enormous results. And we are not stopping at that just concept of Dichoptic. We are also looking at how to improvise their fusion and stereopsis by the same treatment protocol or management protocol by Dichoptic therapies. Now, a standard management protocol, what we follow in Dichoptic is 1 hour is standard by even pediatric eye disease investigator group is following the same protocol, 1 hour per day, at least 5 days in a week, and for 6 weeks. The first 10 session, what we work on the anti-suppression activities. So if there are suppression, severe ambulances, work on the anti-suppression activity, you work on the flat fusion, and then at last 10 session, you work on their stereopsis development. And we found out even many of the places, so these are data I'll be presenting from 3 eye centers from India. So we got 150 total anisometropic patient. Again, this was given in 3 of the centers. So we have divided into 3 components. So anisometropic in right eye, 56 patient of median age of 9 years showed almost 4 lines logman line improvement in 6 weeks. Then in the left eye, it shows again around 4 lines. So there was no inter eye difference between right and left eye. But what happened in cases of isometropic amblyopia, so again, you get a similar kind of improvement, and there was no inter eye difference between right and left eye, even in this group. So as the outcome, which is not only the visual acuity, especially in binocular therapies or Dichoptic therapies, what we observe interestingly that all anisometropic amblyopes almost, so in cases of right eye, it was 90%. So 50 out of 50, 45 gained stereopsis, even though there was a strong suppression at the initial level of the management program. And in cases of left eye, it improved in 42 cases out of 53. So 80% of gain their visual stereopsis from an absent state. And in case of isometropic, all of them gained their StereoAcuity. So this was the major outcome which came from this group, apart from the visual acuity that had improved. So if you see the outcome measures in cases of Dichoptic therapies, the measure or the advantages that we observed in any kind of Dichoptic therapy, that the compliance is excellent. In our this perspective group, we got more than 95% patients who are adherent to the protocol because of interactive games. And the improvement was very fast, as we talked about 3 to 6 line improvement only in 6 weeks program. So that was second observation. And almost 90% of these subjects restored their binocular vision in terms of the stereopsis. And even in another cohort study, what we are doing, we have done more than 100 patients now, that it is also effective in older age group. And older as in I'm talking about 18 to 59 is the age group that we worked upon, and that also has around 3.5 to 4 lines visual acuity improvement along with their binocular vision. And this is 3 years cohort data. I'm talking about the recurrence. There is no recurrence of all these patients who underwent this Dichoptic therapy, not even a single line, especially in the logmar acuity we talked about. We have used the ATTRS chart, and there was no recurrence of amblyopia. Now, if you look at the outcome, in which cases the Dichoptic therapy works best is whenever there is a proper motor alignment of the eye. So if you look at the strabismic amblyope, you need to correct them. So you need to align them better, and then only you can incorporate into the program. So straightforward, if it is of anisometropic amblyopia or isoametropic meridional amblyopes, they're the best to yield the results in case of dichoptic therapies. And in cases of strabismic, you need to alter your management plan. Traditionally, you patch them, improve them, and then do the surgical intervention. Whereas if you are planning for a dichoptic management, you need to align their motor fusion, which is needs to be there even before enrolling for this dichoptic therapy. Now, if you have somebody with eccentric fixation, you need to rule them out. So those are the cases you are not going to get a good amount of improvement in dichoptic therapies. So bifoveal fixation, again, a good clinical indicator whether to enroll for dichoptic therapies or not. Now, if somebody having eccentric fixation, for those group of patients, we have another cohort where we observe that their near vision acuity improves significantly, but distance vision usually limited to 1.5 lines in the improvement of their binocular vision. And in terms of the binocular vision, they become monofixator, so we get good amount of flat fusion for near. Distance stereopsis still a major concern for patient with eccentric fixators. Coming to this program, we are very proud that one of this Make in India product that giving a very good amount of dichoptic outcome, and we are privileged to be one of the first mover into this field. And thank you, Dr. Suma, for giving me this opportunity, and we'll be sharing many more results in coming months.
Thank you so much, Mr. Oli, for a very wonderful presentation. Now, I would like to ask a few questions in the chat box. Which cases do you choose for binocular dichoptic therapy or monocular therapy, or do you have any fixed criteria where you go for?
So one thing I would like to tell Suma, the MFBF therapy is not actually a dichoptic therapy.
Exactly, yes.
What I have been pointing out. It's different from dichoptic. MFBF is like you don't have a low contrast, a high contrast stimuli with integration of binocular function. It's not like that. It is one eye seeing the background, the other eye seeing the target. I've used the red-green anaglyphic filters with the red ink, which is also, which was not a computerized form. You can do MFBF even by that mode. See, so it's just a different concept. It is, what do I say? It's a slight in between. It's in between the patching and it's in between the dichoptic therapy, the binocular therapies.
Deprivation amblyopia, in fact, it was very surprising. We saw more lines improvement. Optometrist Prem has done a study, and he has found that there's more line improvement with maybe the visual acuity which you start with, and he has found more visual improvement, because in isometropic amblyopia there is a 2 or 3 lines improvement, but more we got with deprivational amblyopia, which was surprising.
One value addition to this deprivational amblyopia, as we was talking about, it is mainly of lateral geniculate body which is affected. So dichoptic or any MFBF works best and yields much superior results, and you can end up in getting around
better results.
Better results.
And that is same observation with us as well. So we have done with couple of child with congenital cataract, and they recovered fantastic improvement around 9 lines, logmal lines improvement.
Exactly. Deprivation amblyopia, we found around 5 to 6 line improvement, and we got it much better. I mean, of course, the lines improvement was more than the anisometropic amblyopia, but that is a completely different. So now, which cases, like you were saying that, Mr. Oli, that you say that the motor alignment has to be perfect before we go in. Like sometimes when we do surgery and there's a residual small amount of micropropia. So do you recommend to do the exercises with prisms, or?
Yes.
How much should be the motor alignment which you can do the dichoptic?
Alignment, I talk about that if there is a residual strabismus or overcorrection in case of surgical intervention or undercorrection. So if it is less than 10 or 12, we give prisms as a must and do the alignment first and start with the program. So what happens in dichoptic therapy, if you have misaligned eye, even if it is microtropic, then they will not able to follow or superimpose the image that comes from 2 eye. So alignment of the motor component is very crucial in any dichoptic activities. So use prism in cases of residual or undercorrection or overcorrection in case of surgical intervention. and start doing this binocular activities.
I would like to what about the cost factor? Sorry, somebody is asking the cost factor for the treatment, the cycles, and I think Mr. Oli, can you, because there's a question for that, like how many cycles will you follow up and how long would you give, and the cost factor.
Correct. So if you see the standard management protocol that we are following is only for 6 weeks. 6 weeks as in you are giving 30 sessions, 5 sessions a week. And in 30 sessions, the average improvement you get 4 to 6 logMAR line. Usually in moderate, mild to moderate amblyopia, you are through with the management protocol. Cumulative cost, as in the compare with the patching therapy, especially the time for the parents needs to devote for the follow-up and the multiple consultation. And if you see the 10 days or 30 days of program, which is like combination of certain factor, if charge is different from North India to South India, from Eastern to Western region, but it is cumulative cost is much lesser than the amblyopia management through patching therapy.
Okay, there are a few more questions for Dr. Manjula and Mr. Oli. I think you can answer them in the chat box.